Yeah, thank you. Thank you very much. And once again, welcome you all for this program. It has been a wonderful program for us for the last 5 sessions we had. Now, the sixth program, we thought we'll have Stricture Urethra. We once again have two wonderful people here with us who will come as examiners. Joy Narayan
Yeah,
Chakraborty. Narayan
Chakraborty, yeah.
Chakraborty is actually, you can see him on the screen. Sir is from Guwahati, and he was the past secretary of the Assam Urology Association. To tell about him, he has got an unique class of both MCH, DNB, and a triple FRCS. If I'm correct, one of the FRCS is FRCS Urology itself. Sir is so much interested in teaching that the moment I requested, Sir, can you be a postgraduate teacher? He immediately said yes. So we have someone who is really interested in teaching you from Guwahati. And alongside Dr. Joy Narayan Chakraborty, we have Dr. Arabind Panda. Arabind Panda is quite familiar to people from the south. He had been in CMC Vellore as a teacher for a very long time. And what I have heard about Arabind Panda, even before I had an interaction with him 6, 7 years ago, is he is one of the most postgraduate friendly persons in CMC Vellore. So he had been an excellent teacher there. For reasons he had to leave CMC Vellore, he went to AIMS Bhubaneswar and continued as a teacher there also. And currently now he's doing in services in Hyderabad. So we have two beautiful people here, Dr. Chakraborty as well as Dr. Arabind Panda as examiners for you. Two candidates as a routine. We have one Dr. Bhagavati Vinodri from Madras Medical College, and we have Dr. Ankit Raj from IGMS Patna. The first component will be Dr. Arabind Panda discussing about the history with Ankit Raj. And the second component will be Dr. Chakraborty discussing the investigations with Dr. Bhagavati. And the next component, all four of them will have an interactions together. And of course, by 8:30, we'll be starting taking your questions. So thank you very much, sir. And Dr. Surender, once again, our presenter as always is there ready to present to you. Over to Dr. Ankit Raj and Dr. Arabind Panda, please. Thank you.
Respected teachers, my dear colleagues, today I'll be presenting a case presentation of a 32-year-old gentleman who is a carpenter by occupation, and he presented to us in OPD with a suprapubic cystostomy tube in him.
Ankit, it will be better if there is one presenter, Surendra, there, let him present, because an exam pattern, you will have your second year presenting and you will be facing. Okay,
yes,
fine, that's good.
That's
Surendra, you can start presenting so that the questions can be taken by Ankit. Yeah.
Good evening, sir.
Yes.
A 32-year-old gentleman who's a carpenter by occupation, who's a known case of bilateral femoropopliteal occlusion, for which he undergone bypass graft surgery on 3rd 10/2021, and on patient on blood thinners. On 6/4/2025, patient developed a right frontal ICH, for which he planned for a right decompression craniotomy with a bone flap. On table, difficulty in catheterization, so multiple traumatic catheterization tried neurosurgery team, but failed. So urologist opinion obtained intraoperatively, then Procor SPC done. Patient came for follow-up, so we tried trial voiding 2 times by blocking the SPC, but both times trial void failed.
It's a very interesting history. So probably, what point of time do you feel that there was a damage to the urethra? At what point?
Sir, after one gentle attempt of catheterization, in the next attempt, sir, when there is a resistance, at that moment, sir, I will realize that definitely something has gone wrong with the urethra, sir. Maybe some false tract has been created.
Likely in this patient, he was catheterized in 2021 itself, because he underwent bilateral femoropopliteal occlusion. And that is the time when there was, because, we know that long-term catheterization, even if it's for a week or so, in certain patients and in patients who have, latex allergy, we can get an inflammatory urethral stricture. even after removal of the catheter. So probably the stricture had actually occurred in 2021, after 2021. Yes. And in 2000, and he probably had a poor flow which was missed because this was obviously an emergency. And when they tried to put a catheter in the stricture, within the stricture, it was not possible. Therefore, it was traumatic. So as you are quite right, if the single catheterization does not go and the patient is in the operating room, it is better to do a cystoscopy right then and there. Because already patient is under anesthesia, cystoscopy can be done if required. And if there is a traumatic catheterization and the urethra is otherwise okay, a catheter can be placed which might reduce the incidence of stricture. Or if it's a very tight, we can always go for internal urethrotomy and put a catheter. On the other hand, a trocar SPC also is an excellent option, which was done in this case.
Yes.
Once you know there's a traumatic catheterization and the trocar SPC was done, what is the next step that you would do normally when the patient comes to you in the OPD?
Sir, I would like to give him a period of rest so that the exact length of the stricture will come up, sir.
Yeah, urethral rest has been described. That will delineate the exact length of the urethral stricture. So if a reconstruction is planned, you do not miss a segment which is already narrow because of the dilatation. So in this case, I would expect that with RGU or with an MCU can be done at the same time, so-called abdanogram, so we can exactly know where that stricture is.
Yes.
We can continue. Please, next.
History of presenting illness, no history of increased frequency of maturation, nocturia, urgency, and post-maturation dribbling, no history of hematuria, dysuria, stranguria, trauma, and no history of suprapubic pain, loin pain, fever, chills, and rigors, and no history of pyuria.
So obviously you feel there's a urethral stricture here. So what would be the difference between urethral stricture and urethral stricture disease? Is there a difference?
Sir, urethral stricture disease, urethral stricture is any narrowing. It can be subclinical, sir. So the patient may not present with the symptoms, sir. But sir, in urethral stricture disease, which is usually, sir, when the urethral lumen becomes less than 16 French in male patients, sir, they will present with some voiding symptoms or maybe a superadded infection, sir.
No, the difference is actually urethral stricture can be traumatic, can be catheter induced. Urethral stricture disease there is usually something like a BXO or what we call lichen sclerosus atrophicus, and that causes diffuse stricture of the entire urethra. In this particular patient, in particular cause, probably prior catheterization, it might be a stricture, paraurethral rather than stricture disease. Stricture disease is more difficult to treat because of autoimmune in etiology.
Yes.
And before doing planning an RGU or an MCU, what are the investigations that you would do for this patient? What are the investigations I would like to say? How would you prepare this patient before you do an RGU and MCU? That would be a better question.
Sir, first I would like to do a urine analysis and urine culture, sir. And if there is any signs of infection, either clinically or on culture reports, sir, I would like to treat it first, sir.
So obviously, with a patient with a suprapubic catheter, you are expecting pus cells in the urine. That can come because of the catheter itself. So you would do a culture, and obviously it would be a catheter sample. How would you take the sample in a patient in a long-term catheter like this patient or some other patient? How would you take a sample?
Sir, I would like to change the catheter, sir, under aseptic precautions, sir. And after changing the catheter, I would like to take the fresh sample.
Perfect. That's correct. That is because if you do not change, you might get colonized growth of colonized organisms. And normally, if you look at microbiology, they would not process a sample which has more than 3 organisms growing in it because they feel that's colonized. So you have done a okay. Can we proceed with the next?
Past history. History of seizure after craniotomy, and patient started on tablet phenytoin, and not a known case of diabetes, hypertension, tuberculosis, chronic kidney disease, and asthma or coronary artery disease. And history of catheterization done during bypass surgery on 2021, and multiple traumatic catheterization attempts made during the craniotomy surgery on April 2025.
Perfect. It just shows what we already discussed. Can we proceed? Anything else is there?
On personal
Yeah.
history, patient had a history of smoking cigarette for 12 years, daily 1 pack per day, and no history of alcohol intake, and patient consumes mixed diet, and no significant family history.
This is interesting. So this gives us the background about why the patient needed a femoral bypass here, or a femoropopliteal bypass, bilateral femoropopliteal bypass. Probably this patient has a vascular disease, a vascular compromise because of his smoking history.
Yes.
So what are the other things that you'll keep in mind when you get a patient like this? He's a young man. He's only 32, it seems, 32, 33. So is it very common for somebody who's 28, 29 years to have this sort of history?
No, sir.
Bilateral disease at that.
No, sir. In his age group, sir, with such a long history of smoking, with at least 1 pack per day, I am suspecting, sir, he is having some vascular disorder, probably, sir, Burgess disease. So because of this, sir, if we are planning him for surgery, sir, he would be a high risk patient, sir. And
Correct.
also, sir, because of the small vessel disease, there would be problems in wound healing after urethroplasty or any other invasive surgery in him, sir.
So that's a very good point. That is probably has some sort of disease, vascular ischemic disease, perhaps Burgess, perhaps one of those. And again, is high risk because it never only affects the lower limbs; it can affect the cardiac vessels also. That's an important point. And second point is he has had a femoropopliteal bypass bilaterally. So if you're going to put this patient in a lithotomy position, you would have to really take care of the padding here, or maybe even if you consider using a sort of yellowfin stirrup, so as not to put pressure on the popliteal area, because then it can lead to rethrombus. The second point is, would you require to give him anticoagulation perioperatively, the pre-op and post-op? That's something important, because then we'll have to be very careful in our surgery, because in such circumstances you can have a hematoma in this surgical site which can get infected, and you can sort of destroy our reconstruction.
Yes.
So, and thirdly, you have to advise this patient that he has to leave smoking, which I think he already would have, and you will try to optimize by how do you optimize? You're going to get a PSC, and then you're going to put him on incentive spirometry. Maybe if he has get a pulmonary consult, maybe he needs preoperative nebulization, or put him on a MDI, admitted dose inhaler, one of those Asthalins or Budicort. We'll have to put all that. Yes. And make sure he's perfectly optimized before surgery. Also, you have said you will do a culture. You will treat the culture accordingly before you plan surgery, because the culture, what culture would you feel is most dangerous when you're planning erythroplasty? What organism?
Pseudomonas, sir.
Pseudomonas, yes, and also some variety of Streptococcus, yes. which can sort of destroy the graft if you're actually planning a graft here. Can we proceed next?
On general examination, patient was conscious, oriented, and afebrile, moderately built and nourished. There is no pallor, icterus, cyanosis, clubbing, generalized lymphodenopathy, and pedal edema. Vital signs: pulse rate 82 beats per minute, blood pressure 130/80 millimeter mercury, and temperature was normal, and respiratory rate was 17 beats per minute. On abdominal examination, on inspection, midline laparotomy scar incision is present, scaphoid umbilicus in midline, and all quadrants move equally with respiration, no sinuses, and bilateral inguinal orifices are free. On palpation, no warmth, no tenderness, and no mass palpable or no organomegaly, and percussion auscultation was normal. And other vascular
Yeah,
systems.
so apart from the midline scar, rest of the thing appears to be normal in this. Correct? Even the other systems appear to be normal. One of the things we have to mention is, of course, what is the status of the limbs, lower limbs, and of course the anterior vasculature. Can you feel the distal pulses? Because
Yes.
obviously you have done a surgery here. The distal pulses, can it be felt? Can it not be felt? Dorsalis pedis, etc. So that was all okay, sir. Dr. Surendra, that part was okay. The lower limb.
Both the sides, lower limb pulse was normal, and we did a Doppler. I used the Doppler for both the lower limbs. It was normal.
Okay, fine. Can we proceed next?
External genitalia, external urethral meatus adequate, prepuce gland shaft was normal, and bilateral testis palpable, and no swelling or non-tender, and scrotum was normal. Digital rectal examination, there is no prostatomegaly, and anal tone was normal.
Okay, can we proceed next? He had a HPC in situ, right? That has to be mentioned.
Yes, sir.
Yes, sir.
Yeah. So, what was the size of the SPC? Where was it located? Was it?
Sir, it was about 3 centimeter above the pubic symphysis, sir.
3 centimeter is a very low. It's extremely low SPC.
Yes, sir. Low SPC.
It was a low SPC. Okay. And what was the size of the catheter that was inserted?
Say 3 centimeters or 3 finger breadths, Surendra?
Yeah, three finger breadths is totally different.
Different. 3 centimeters only, is it?
Yes, sir. Because of the midline laparotomy incision, they put the SPC trocar below that, sir.
Now, two things happen. Arabind also will agree with me. Two things happen when they do a midline laparotomy incision. Sometimes trocar is placed either on the site of the incision itself on the midline, or they prefer to place it some 2 centimeters away from the midline on a safer reason. If it is 2 centimeters away from the midline, then it's actually a little difficult for us to manipulate from above if required. So, Dr. Arabind exactly wants to know where exactly was the SPC. Is it in the midline or 2 centimeters away from the midline?
It is in the midline, sir.
It is in the midline. Okay, that's fine.
Sure.
Arabind, at this stage, can we request Ankit to summarize his findings and give some reasonable diagnosis so that we can take Dr. Bhagawati and Dr. Joy in? Yeah, Ankit, can you summarize yourself? What exactly has happened from the discussion which has come with Dr. Arabind?
Sir, to summarize my history, sir, a 32-year-old gentleman with a suprapubic tube in situ, with prior history of traumatic catheterization, has come to us after 2 failed voiding trials, probably a case of traumatic urethral stricture disease, sir.
No, actually, the point which Dr. Arabind was stressing you again was in 2021, he had a history of catheterization.
Yes.
And he also has a vascular disease. There is every possibility when the catheter was removed, he has gone for a stricture. See, the longer the catheter stays inside, there is even a study that says if the catheter stays for more than 3 weeks, the probability of developing a stricture is even as high as 22%. That too in a developing country like us, where we don't use regularly our silicone Foleys, we use only the latex Foley catheter. The longer the catheter stays, the longer the chance we can develop a stricture. So Dr. Panda actually tells you that this patient in between 2021 and 25 had actually developed a stricture. That is one of the reasons why there was a traumatic catheterization when they made an attempt in 2025 in the OT. We trust our doctors who are trying to make a catheterization, right? They were not able to catheterize because this patient probably had a stricture by that time. And it could have been a stricture disease also. It could have been a long segment stricture also. So these things you will have to keep in mind before you proceed further. So here is a guy who has got an SPZ. He has got a stricture. You're thinking there is a traumatic stricture. That is a high possibility that he's already had a stricture. And trauma is probably because they are not able to negotiate the catheter. They probably started straight away with the 16 or 18 and they found trouble in going inside. That's what has exactly happened.
Yes.
So I think that's what you want to summarize. You have any other differential diagnosis apart from a stricture in this patient? Nothing else comes to your mind. No, young man not able to catheterize, they put an SPC. And
Sir,
one point,
since I have not examined him, sir, there can be meatal stenosis, phimosis also,
Surendra
right?
has examined him and he has told the meatus is normal. There is no BXO changes. Let's believe Surendra. Everything is normal. Now, one point Dr. Arabind made
Yeah,
was very
can I come
important.
in?
Yeah,
One thing
please,
has
sir,
been
please. Yeah,
one thing
please.
has been missed here in examination part. Examination of the urethra. We have to palpate the urethra. Sometimes undetected stone can be palpated in the urethra, in the distal urethra, or the proximal urethra, the penile urethra. So palpation of the urethra is an important part of the examination.
Yeah, Joy, 2 points here. One,
In
sorry,
stricture
and the 2 points here.
suspension.
One, Dr. Joy is trying to make is we have seen a lot of patients where a small stone forms as in a routine guy, it doesn't pass out because there's a stricture already, it gets stuck there. Because that is an
Yeah.
additional point for you when you examine. The other point which Dr. Arabind was trying to make is if you have all the setup with you, there is an opportunity to do an urethroskopy and put in a catheter alignment straight away, even at the time of injury. That would have been great. But
Yeah.
anyway, most of the government hospitals do not have that setup. Fine. Arvind, can we now move to Dr. Joy Chakraborty sir and Dr. Bhagawati?
Yes, sir. Yes, sir. We should. We should.
Yeah, please.
Hi,
We'll be
Bhagawati.
staying on time with you, sir. Hi, sir. Hi, sir.
Yeah. Let's move on.
Yes, sir.
Yeah.
So, as an extension of the examination, I would like to do an ultrasound of the kidney, ureter, and bladder for this patient, sir.
Yeah. For what?
Sir, one is to look for the bladder wall thickness, sir. Another one is look for any hydroureteronephrosis if it is present, sir.
Yeah. Can we summarize the history part? See, in the history part, if you see that the patient was not having any LUTS, no dysuria, no symptoms, all symptoms are, but one thing we have not asked, how was the patient peeing in between the first operation and the second operation? That was not asked. Just before the intracranial surgery, was the patient peeing on his own? And if he was peeing, how he was peeing? What was his flow like? So that part of the history is omitted. Now coming to the next point, let us think that there might be one stricture. They all are now assumptions. There might be stricture, may not be stricture, or there may be, or sometimes we operate and do some junior staff to do the catheterization, and there might be some injury while the catheterization, and the SPC was a very good job done in this patient. Now, how will you proceed now? And this patient, we have to remember that the patient is already on anticoagulant and he has been operated for intracranial hemorrhage.
Yes, sir.
And bilateral femoropopliteal stent. We cannot put the patient easily on lithotomy position. So we have to exclude many investigations now. Yeah.
Yes, sir. So after the ultrasound KVP,
One hint, Dr. Chengal already has. Yeah.
Yes,
Sure.
sir. Yes, sir.
Yes, sir. I would like to do a routine blood and urine investigations after that, sir. To
No,
look for.
Bhagavati, you wanted an ultrasound.
Yes, sir.
Your ultrasound has not been shown. You want to do the blood investigation,
Yeah.
urine investigation, or you want to go with the ultrasound?
Ultrasound followed by
Aravind
blood and
has
urine.
actually made a point already how to do an urine culture. That is also a routine exam question. When you have an SPC, how to do an urine culture, and what is COTI also. When a patient is symptomatic, how do you say what is COTI? More than 10 to the power of 3 when the patient is symptomatic, not the classical 10 to the power of 2. And the biofilms, everything Arvind sir has explained already. So you want to go with the ultrasound?
Yes, sir.
Going with the ultrasound. Dr. Joy sir asked you a question. Why are you going for ultrasound in this case?
So this patient, one is look for any bladder wall thickness, sir. And another one is to look for any hydroureteronephrosis if it is present, sir.
Yes. Any other thing?
So long-standing obstruction, that could be some changes of neurogenic bladder like trabeculations or diverticulum, which we can see in an ultrasound, sir.
Can we examine the urethra also from
Yes, sir.
outside? Yeah.
Yes, sir.
Yeah. Next.
Next, I would like to do.
Other investigations?
Sorry, sir.
Yeah. Ultrasound is given here.
Yes, sir.
Yeah. 18 cc, left kidney, right kidney almost normal in size. No hydronephrosis. Now, what will be our next step?
So after this, I would like to do a routine blood and urine investigations for the patient, sir, in the form of complete blood count, RLE, PTINR, urine routine, and urine culture, sir.
Yeah, urine routine, urine culture already been given. Now
Yes, sir.
investigations here.
Yes,
Yeah.
sir.
Now pus cells 1 to 2, high power field. That's ultimate normal. And urine culture hasn't been given, no growth. Yeah,
growth.
it's no growth. Now, KFT.
We have a
Creatinine,
creatinine there.
yeah, creatinine 1.3. Next, what?
So next, I would like to do a retrograde urethropography along with a mixture sister uretrogram, sir, since SPC is present.
SPC is present. Well,
Yes, sir.
is that available? RGMCU is yes.
Yes, sir.
That is RGMCU.
Yes, sir. So
What will be your finding?
So first, I would like to see the scout film, followed by the RGO film, and then the VCU, the contrast via the SPC, sir. So in this, there is a narrowing present in the mid-bulbar region, sir, of the urethra.
Mid-bulbar region of the urethra.
Yes.
Now, what are the parts of the bulbar urethra? Can you hear?
Yes, sir.
What are the parts of bulbar urethra? Okay, let us not consume time. It's proximal and distal bulbar urethra. Now,
Yes,
what
sir.
is the, yeah, now where is the urethral blockage here?
Sir, at the level of the mid-bulbar, sir.
Now, can you specify any length? You have to already told the location.
Yes,
What
sir.
will be the length?
Sir, by seeing the OUG, roughly the inferior pubic rami corresponds around 2.5 centimeters, sir. So roughly this will be less than 1.5 centimeters in length, sir.
So
How do you how do you make these things that this length is going to be that much? Or do you have any particular parameter against which scale against which you can measure the length?
Sir, roughly.
And can you comment? It's a good idea when you are commenting on a particular investigation to ask to see all the images before you start commenting.
Okay, sir.
Because you started commenting only by looking at these two images, and you said that I wanted MCU also, I want a wording film. There is no wording film here. So see all the images before you start commenting, so you'll be able to give a better answer.
Okay, sir. So I'd like to look at the voiding film also for this patient, sir.
We have a wording film.
Surendra, do you have a
No,
voiding
sir.
film that shows the bladder neck open? No.
No, sir. No, sir. No voiding.
No voiding film.
No
Or we can take the first film is actually the patient is trying to void, still the bladder neck is not open. The second film, Arabind will take it, the second film, the bladder neck is not open in spite of the patient trying to void. So Bhagavati, what will be your impression? If the patient is trying to void, still the neck is not opening. Joy sir is asking you that question now.
Sir, one patient could be an anxious patient, sir.
Yeah.
So,
Then?
very rarely that could be some associated or radiolucent stone or some primary like bladder neck. Very rarely, sir. Bladder neck obstruction could be one cause.
So what will you do in these patients? If you feel the patient is anxious,
Yes,
what can you do in this patient to open the bladder neck?
sir, I would like to give silodosin and then do the imaging, sir.
So you like to give an alpha blocker, preferably an silodosin, which acts a little early, around
Yes,
2 to 6 hours, so that you see it's opening or not. Many times, in spite of that, also it doesn't open. But since there is no associated pelvic injury in this patient, probably there is no associated bladder neck injury also. He is a little anxious. That is why he is not. If you see the AIG picture, are you happy with the AIG picture? You are seeing both the operative foramens. Do you like to see both the operative foramens? You want to see only one operative foramen?
Sir, ideally, correct position, only one operative foramen should be visible, sir.
Which should not be seen, the dependent or the non-dependent? Which should not be seen?
So the one where the urethra is stretched, that side, it shouldn't be.
So the dependent
Yes,
one should
dependent
not be
portion.
seen.
Yes,
But
sir.
anyway, we see it in most of the films. Why is that leg stretched there? Why should the leg be stretched? Why should be abducted? Why is one femur abducted, other femur is not abducted?
So that we can visualize the entire urethra, sir.
Then when you can visualize the urethra, otherwise it will be merging over the urethra.
Yes,
That's
sir.
one of the reasons why it is deflected away. Now, Dr. Arabind sir asked you a point. Dr. Joy sir asked you a point which you knew the answer, but you didn't answer. He asked you what are the parts of the urethra, because you said it is a mid-urethral stricture, mid-bulbar stricture. He asked
Yes,
you what are the parts of the bulbar urethra. Can you tell the parts of bulbar urethra to Joy sir, please?
yes, sir. Proximal and distal, sir.
Proximal and distal. Then Arabind sir asked you which is proximal, which is distal, which is mid-bulbar, and what scale you have
Yes,
to
sir.
say this is a 0.5 mm stricture.
Sir, roughly the line corresponding to the ischial tuberosity corresponds to mid-bulbar stricture, sir. And the line joining the lower border of the obturator foramen corresponds to bulbomembranous junction, sir. And the starting of the bulbar urethra is roughly at the level of the penoscrotal shadow, sir.
Fine. So these are the answers which you know, but see what has happened in the exam. When the examiner is asking you a question, you're not able to answer. That is where you need the internal to support you. Now I'm acting as an internal Arabind for them. Okay.
Yeah,
Okay.
yeah,
Good. Yes.
can I come here
Please,
in
sir,
this
please, sir. You
picture?
have. Please, sir. It's your this thing. I'm only
No,
interviewing.
no things. In these images, how the contrast was given. Do you have any idea?
Sir wants to know whether the contrast is given from
How
below
the
first or
contrast was
above
given
first.
here?
Oh, sir, in the first film, the contrast was given from below, sir. They have stretched the penis and they tried. The
I
contrast
think
was
we have to believe the second film is the first film.
The second film is the first film, sir.
Second film is the first film. Yeah.
The contrast was given via the SPC, sir.
Yeah. And argivin given whether a Foley's catheter is used or a Brodny clamp or something like that is done, which is more reliable.
Sir?
Oh, no, sir, but sir has a very interesting question. When you do a RGU, there is something visible near the glands. Radio opaque thing. What is that?
Sir, one could be a Brodny clamp, sir. And
Do you know
here,
any other name of any other clamps?
Knudsen's clamp, sir.
Oh, fine.
Yeah. So here clamp is used. Okay.
Yes.
Now, yeah. Now, is there any other alternative to look for the proximal urethra? Suppose you want to evaluate the proximal urethra and then the patient, after giving anything, the proximal urethra didn't, or prostatic urethra didn't allow contrast to come down. So already the patient is having SPC. Can you see the proximal urethra by any other means while the patient is still lying down in normal position?
Sir, one non-invasive could be a sonourethropy can be done, sir.
Sonourethropy will not give you a great answer because it will give you a stricture segment, but you want to see the proximal segment here.
Then
Sir
we
is
can
asking about the proximal urethra.
So then we
And
can inject.
sonourethropy, you have to have a medium there. You have to have gel there.
Yes, sir.
And your gel is not going to go to the proximal urethra.
So then via SPC we can inject contrast and then
Yeah.
You already injected,
via
right?
SPC we can simple put a,
Yes, sir.
a flexible.
Yes,
Via
sir.
SPC we can simple put a flexible scope and see.
Yes, sir.
Yeah.
That's a very good idea because you need to see that. And now you have digital scopes.
Yeah.
You can carry it anywhere. You can carry
it can be done on the bedside also.
Yes.
Yes, sir.
Now next, what is your plan in this case? Any other investigations would you like to continue, or you are satisfied with this finding?
I'm fine with this, sir.
Find this.
Yes.
Now, let us move on to Arabind and Chengal, Dr. Chengal. Yeah, you are open, sir. Now.
Yeah.
I think I've asked all the questions. Let's move next. What would you like to do next for this patient? You'll take the clearances, of course, and all that, optimize the patient. What else? What is your plan for this patient?
Yes,
all
sir.
that is done. Now you've taken over the next plan. We'll assume that the stricture is what you are seeing there, and the proximal part of the bladder neck and is all over. Bladder neck and the prostatic urethra is normal. There is no problem there. Now you've got a short segment mid proximal bulbar stricture there. Now, what is your plan? What is the next plan of action? What would you do next for this patient?
Sir, I would like to do a cystourethropy followed by a DVIU for the patient, sir.
DVIU. Do you have any other options? Dr. Ankit, do you have any options? Anything else that you would like to do other than DVIU? What is the success rate, Dr. Bhagwati, for a DVIU, long-term success rate?
Sir, approximately around 40 to 50% only, sir.
Is even less than that. And this is a tough stricture. This is not a flimsy mucosal level stricture. This is probably catheter-induced, maybe also accentuated by the trauma that was later. So this would be a tough stricture. The success rate for this patient would be even lower than that. In fact, it would invariably fail without if you are not going to do a self-calibration routine regularly. So what are the, you have any other options, Dr. Ankit? Would you think of any other options for this patient?
Sir, I
Excision.
would like to discuss with the patient, sir, the options available to us,
What
sir.
would your first option offer would be?
Sir, I will give him options of DVIU, sir,
Hmm.
and non-transecting anastomotic urethroplasty.
Hmm.
And also, sir, we can do a EPA here, sir, since the stricture segment is short, sir.
Okay, non-transecting. Dr. Bhagwati, non-transecting. Would that be ideal operation here? Non-transecting urethroplasty. What is done in a non-transecting urethroplasty?
Sir, we don't transect the portion, sir. We just anastomose it without transecting.
How do you understand the mucosa? What about the significant spongiofibrosis, which is probably the case here?
Hmm.
So that may not be a great option. Would you consider doing a dorsal onlay buccal maxillary urethroplasty in this patient?
So the length of the stricture is it's a short segment stricture, sir.
Yeah, I was asking you. Would you consider? Would you not consider?
You ideally done for more than 2 centimeters stricture, sir. But this case is less than 1.
No. Why do you want to do 2 centimeters? Shorter the segment, better the result, isn't it?
Yes, sir.
So the
The
length.
Correct. Arvind, the question was perfect, Dr. Bhagwati. Although you would like to do an IU for this patient, you
Yes,
had yourself committed the success rate of IU is not good. Only in selected cases, success rate of IU is 50 to 70%. Just of the cases, only 29 to 31%. In which case, if an erythroplasty here in this patient can give you a 98% success rate, why don't you select that for the patient instead of going for IU? That was the question to you. So, would you consider?
Yes, sir.
Yeah, but if you want to do an internal erythrotomy, Joyce sir, in your practice, do you routinely advise sonourothrography when people are planned for internal erythrotomy, sir, to know the nature of the stricture? Although we
No.
don't do it in a government setup.
Routinely doing sonourothrography is not have any relevance due to for operative. Only palpating the urethra, we have got a very good idea about what is the degree of spongiofibrosis. And sonourothrography, although it's a more, it is in some literatures it is written that it is more specific in delineating the length of the stricture and location of the stricture and degree of spongiofibrosis, but it is operator dependent and not all centers can do it clearly. So although we know that RGO and MCU give us a two-dimensional picture, we have to take decision on this only and our physical examination findings. Yeah,
So that point Bhagwati sir is trying to make, is important, because in a sonourothrography, you can assess the length of the stricture. To some extent, you can talk about the spongiofibrosis. The best investigation for spongiofibrosis will be an MRI. In fact, we don't do it as a routine. But clinically, when you palpate, you feel an induration. That means this spongiofibrosis has extended beyond the spongiosa and it's gone to the surrounding tissue. There, your internal erythrotomy is not going to help you. That is why Sarah was stressing right from the beginning, did you examine the urethra? Did you examine the urethra? If you palpate something there in induration, this is probably not a candidate for internal erythrotomy. I think that's what you were trying to mention, Chakraborty sir. Yes. Correct. So, Arvind, still Dr. Bhagwati wants to do an internal erythrotomy for this patient. Your opinions on that? Because for these cases, we do internal erythrotomies. We give them a choice once. Let's see a minimally invasive.
Definitely okay. It's possible to do erythrotomy as long as the patient accepts that there are other options. Plus, this is a complicated case. You have patient anticoagulation. So it's a valid choice as long as the patient knows that success rate may not be that high. So can we proceed? What was done in this patient?
Ankit sir wants to know what was done in this case. Surender, what did you do for this case?
Sir?
You did an internal erythrotomy for this case?
Sir, we did a internal first up and down scopy, sir. Then we proceed with the internal erythrotomy, sir.
Yeah. So I just want to ask one more point to Dr. Bhagwati. Yes. What is your opinion on an augmented roof strip urethroplasty for this patient?
Yes, sir. That could be done, sir.
No. When would you do? Forget about this patient, but when would you ideally do augmented roof strip urethroplasty? So basically, we are going to plan that out when you are not 100% sure that there is no other inflammatory segment, or this segment may be little longer than what it is. As you said, excision with prostomosis is a good choice for a short segment stricture, but sometimes there may be a segment which is inflamed and which has spongiofibrosis even distal or proximal, considering the fact it may be a long-term catheter-related injury. So you have to actually, when you go for reconstruction of any patient, you need to go in with all your skill set, and sometimes it's on the table that you really have to make a decision of which way to go, one way or the other, looking at that stricture. So that sort of thing. So I think Sir, would you like to add and comment?
Arvind, can we ask them how they do an internal ureterotomy? It's very important for them. That will be an operative segment of them also. Yes. Bhagavati, can you take that question?
Yes, sir. So first, I would like to put a 6-7.5 URS scope and then visualize the stricture and negotiate a guide, thermo guide via.
Can you explain why you wanted to use that 6-7.5 ureteroscope very specifically?
Sir, 6 French because sir, stricture.
No, by classifications, classification, can you tell us, is there any classification, EAU classification, that tells you the size of the stricture, which is 0, 1, 2, 3, 4, 5? There are two classifications which are important for you from an exam point of view. One is the EAU. Other one is our own Ravi Purohit and Blaivas classification. So both the classifications you have to know.
Yes, sir.
Can you tell one by one EAU classification first?
Yes, sir. So EAU subclinical stricture, sir, is 1. 2 is low grade stricture, which is around 11 to 15 French, sir. 2 is 4 to 10 French. 3 is less than 4 French, sir.
Okay, now, fine, you're okay. One is you are able to negotiate beyond a 16 French comfortably. The one is you're not able to negotiate beyond a 15, 11 to 15. Yes, then you're up to 4 and 1 to 3, and you're not able to see anything, all those things. Now, you are using a 6 French ureteroscope here, right? Yes, what is the reason why you're using a 6 French ureteroscope here? You could have as well used a 16 French flexible cystoscope. Joyce sir is smiling. Now, why is that? What is the importance of 6 French? What is the importance of 16 French in a stricture?
Yes, sir. So 16 French, definition of stricture is anything less than 16 French, sir. So if 16 French passes, it means patient has subclinical stricture, which is more than equal to 16 French.
So why can't you say the patient doesn't have a stricture if 16 French goes in? Why are you using the word subclinical stricture? You said by stricture definition is anything less than 15 French.
Yes, sir.
So 16 French goes in, even with difficult, comfortably negotiates. It's not a stricture, right? Why are you using the word subclinical stricture? That is because you people wouldn't have read one article which came in 2003 UCNA that not only says 16 French or less than 16 French is stricture. Whenever the patient has an obstructive symptoms and a peak flow rate less than 7, when the patient feels that I am having a difficulty in passing urine, my urethra is not normal as the caliber it used to be, my speed has come down, even those symptoms have to be taken as stricture symptoms only. That is why even if your 16 French goes in and you have a clinical diagnosis of stricture, you brand it as a negotiable narrowing in the urethra. We used to write 20 years ago, negotiable narrowing in the urethra. These are nothing but subclinical strictures nowadays classified by EAU. Okay. So what is that 6 French? Now 16 we understand. Below 16 you call it as a stricture. Whatever may be the grade. Why 6 French? If the urethral plate is 6 French wide, you can preserve the urethral plate in any stricture disease, over which you can do a substitution urethroplasty. That is the reason for 6 French. So now I think you have gone with a 6 French ureteroscope. Can you tell us what you will do for this case?
So first I've kept a guide wire inside, sir. Negotiated the stricture and kept a guide wire inside. Then I use a 21.
You prefer a guide wire or you prefer an ureteric catheter in this patient?
Sir, if ureteric catheter is available, I would prefer a ureteric catheter, sir.
So what advantage you want to give by using an ureteric catheter?
Sir, 2 advantages, sir. One, we can measure the length of the stricture. Another one is we can check if the ureteric catheter is placed in the bladder, sir, by looking for the drops of urine which comes out via the ureteric catheter, sir.
The only careful thing is we will cut the ureteric catheter. Usually we don't cut the guide wire when you put an iron knife. You can cut the ureteric catheter. This has happened to us many number of times. Okay, you put in a ureteric catheter, but then
yes,
Chakraborty says, sorry, please take over. I am just
no issues. You are going in the right way. No problem.
You can explain, Chakraborty sir. Yeah.
Yes,
Yeah,
sir.
either we have put a guide wire or a ureteric catheter, whichever you feel comfortable with it.
Yes,
Because
sir.
yeah, you can measure it with also ureteric catheter also. And always remember that in this two-dimensional RGUMC, we underestimate the size of the
Stricture.
stricture. Always we underestimate. So by seeing it intraluminally, we can have and in that way, we can have if this is occlusive stricture and where there is a small hole, pinhole, ureteric catheter to some extent will make a lumen out of it. And it will be very easy to pass a 6 French or 6.5 French ureterus. So after making that, it will be much easier for us to place a DVIU incision. Now, whether you want to go for a hot or cold DVIU, now it depends on you. Now, in this patient, which one you will prefer, hot or cold?
So what we have been
DVIU.
following is a cold DVIU, sir.
Cold DVIU.
Yes, sir.
This patient is already on multiple anticoagulant. You cannot make the patient for a long time in a lithotomy position. Do you still go for a cold DVIU in this case?
In this case, I would like to do a hot DVIU, sir.
No, why? What is the reason? Why do you change? Is there any difference between hot and cold?
So, yes,
And
sir.
is there any
Cold we use a
evidence?
cold knife, sir. The Sassy's knife.
Is there any evidence? I know Versace's knife. Is there any evidence that if you cut with a laser, the results are any superior or are they inferior?
No, not sure. Not sure about it, sir.
More spongifibrous. No,
Or
many.
you-
If I go to put a catheter, the bleeding may not be significant.
Yes, sir.
So probable idea of Dr. Joy sir was to say if we have a laser, there is a chance you can coagulate the bleeding also
Yes.
simultaneously.
In this case, see, in this case, this patient is already on multiple anticoagulant, humeropopliteal. So it will be very easier for us if we perform a hot by holmium laser or whatever, thulium laser, whatever we use in the urethra and make a cut comfortably in the 6 o'clock position or in the 12 o'clock position after putting the guide wire. And in this case, we can do it on the patient in supine position by using and I have done a lot of cases like this, which we can't do anything by putting a ureteroscope. You put a biorad or 200 micron fiber and put a small incision, precise incision, and you can coagulate also at the same time. And that have a very good control while putting the incision with laser rather than on this little bit blind. 50% of the YU is blind because we have to make a 12 o'clock incision. So we have to remember in this patient particularly. In other patients we can think in a different way. In this patient, using a flexible ureteroscope and 200 micron laser would be a wise, very, very wise decision, I think. And after that, you just dilate the stricture with a Teflon dilator. The patient will not have any bleeding.
Good, Joy sir. That's a
Move on,
very nice
move on.
point which we generally do not discuss in our classes. It's a nice point because Sarah has been doing a lot of cases, as I said, with flexible and laser. You can do it off in a supine position also in this particular patient. We are a little worried about putting the lithotomies. It's quite nice. So let us assume now we classically you do an internal erythrotomy in this patient. You have not tried a laser. You have done internal erythrotomy with sachet knife. How far you cut? Where exactly do you cut? Or can you request Ankit to take that question? Ankit, can you answer this question? Where do you cut and how far do you cut?
Sir, at our center, sir, we cut at 12 o'clock, sir.
Now, every center we cut at 12 o'clock. Can you tell why you cut at 12 o'clock? Arabind sir is ready to ask that question. He is waiting for you. Yeah, please, Arabind.
No, absolutely okay. 12 o'clock is absolutely, you cut at 12. Most of them you cut at 12.
Specific reason why you wanted to cut at 12. That's what the next question is.
Sir, we cut at 12 o'clock, sir, and then
Why?
after,
Why 12 o'clock? Why 12 o'clock? Is it convenient for you 12 o'clock or there should be some reasons, right? Why? See, one, the blood supply of the urethra, if you see, consistently it's either at 2 o'clock, 10 o'clock positions, or it goes to 11 o'clock, 3 o'clock positions. Generally, it doesn't come up 12 o'clock position, but in spite of that, it bleeds. That's a different thing. The other important thing, when you cut in the bulbar urethra, that is place where the pleura diverges. So the pleura is actually not there. So if you cut in the anterior urethra, internal urethrotomy, you will enter the corpora cavernosa. In the bulbar urethra, the pleura are diverging at 12 o'clock positions. Even if you cut deeper, you are not supposed to enter the corpora cavernosa. That's one of the main reasons. Okay, fine. Go ahead.
And
Would you prefer, what sort of sachets knife would you prefer? Would be a personal preference? You can use any one, but what would be your personal preference? What are the types that you know of?
sorry, sir, no, I have no idea, sir.
There are different
There are
types.
3 or 4 different types of sachets knife. The most commonly ones that you see are the half moon one and the straight knife. Both of these knives are to be used differently. The half moon one is a forward cutting knife, where you cut bit by bit the stricture, and as you divide the stricture, you go forward. The straight knife, the thin knife, is a knife that is to be used in a sort of retrograde cutting fashion. So actually, you enter that stricture and you come back retrogradely cutting that. There are of course different knives that are sort of serrated, sawtooth knives, which can be used for more tougher strictures, but these are not very commonly seen.
Yeah. What is the degree of scope you will use here?
0 degrees, sir.
Yeah, very good. 0 degree. That's okay.
And it will be a sort of a passive. You prefer to use a working element that is specifically meant for a EIU. Though I know that many people use a passive working element for EIU. It is better to use something which is only meant for EIU, because that's far more stronger. It's complete metal. It's far more stronger rather than using a passive working element, because a passive working element can actually get damaged if it's a very tough structure.
Yes.
You have seen those elements, Ankit. Sir is talking about one passive element which regulates for TURP that is used for IU also. There is a separate IU which is a forward cutting. I mean, hand movement, thumb movement is forward. Have you seen that?
Sir, at our center, sir, we have that for TURP, sir.
Yeah. In every center, we have started purchasing only the TURP things, not the other thing. It was a very famous question in the exam. If the examiner asks you this question, which one you will buy? You want to buy both or you want to buy only TURP? That means you are passing the exam. That's the last question you usually ask you in the exams. We are going to give you the privilege of going and buying instruments. Okay, okay. Now, the other question, I think Bhagavati knows the answer for this. Why should you go into the bladder and put a catheter? Right? And once you cut the IU from here, you can put a catheter from here itself, right?
Sir, so first we would have cut only for the scope to pass inside, sir. Only while coming out, we will know the exact length and we can cut more and come out, sir. After going inside the bladder, while coming out, we cut the stricture more and then we come out.
So when you come out only, you'll know where the external sphincter is.
Yes, sir.
That's where you decide on cutting the stricture more.
Yes,
After
sir.
seeing where the sphincter is.
Yes, sir.
Sir, Joy sir, in this patient, they have done an internal urethrotomy. We have got another 6-10 minutes to go, sir. They have done internal urethrotomy in this patient. They have put in a catheter. Would you like to know how they want to follow up this patient? Sir, patient is on a catheter. Ankit, with Joy sir, can you discuss how do you want to follow up this patient? They
Yes,
put
sir.
in Celastic Foley,
Yes, sir.
16 French.
Sir, we remove catheter after 7 days, sir. We call, after discharging the patient on day 1 after surgery, sir. We call him on day 7. And early in the morning, sir, we remove the catheter, sir. And we wait for him to void, sir. Once he voids successfully, sir, we tell him to follow up with us, sir. So at our center, the follow-up schedule is, sir, we teach him on day 7 of the visit, sir, when he first comes, we teach him self-dilatation, sir. And we advise him in the next 2 weeks, sir, to self-dilate the urethra thrice weekly. Then, sir, once weekly for next 1 month, and then, sir, monthly. And, sir,
Okay.
we call him, sir, whenever he has any voiding symptoms or any evidence of urinary tract infection. And on, sir, 3rd month, we take him for a uroflowmetry, sir.
Yeah.
Anyway, different centers have different protocols. Let's go with Joy sir now. Yeah.
Let us start first from the putting the catheter. So you have put a catheter, and what will do with the SPC?
Sir, we keep both.
After operation.
We
You
keep
keep
both,
both.
sir. Yes, sir.
Why? It is
Uh,
not
sir,
a it is not a urethroplasty case, it's the OIU
yes,
case, DVIU.
yes.
So why should you put a SPC? It's a short stricture, you have done a good OIU, and after that, should you keep the SPC in situ? Then after 7 days, how can you do the
There are certain advantages of removing the SPC on the table. One advantage is, as you are keeping the catheter for 7 days, this SPC tract will completely close because of the catheter drainage periurethral. If the advantage of keeping the SPC is, suppose this stricture is a very tough stricture and it sort of collapses immediately after AIU, or there is a false passage through which it has gone and it collapses immediately, you still have a SPC which you can open and sort of relieve the patient. But I agree with Joy sir that you can remove the SPC if you wish, because this is you've done a good EIU, wide EIU, you put a 16-18 French follies, silicone follies. The patient should void. And if the patient doesn't void anyway, you're going for urethroplasty. I don't think EIU is an option here.
Thank you. The second scenario is that you have removed the SPC, you have given one single stitch there, and you experienced a very tough stricture. Although it is looking very flimsy here, it is a tough stricture, and you thought that you have went inside the bladder and the catheter will go inside very easily. You have removed all your equipments. You tried to put a 16 French catheter. The catheter didn't go inside. What will do? I will put it inside then. Now you have lost your access.
Sir, I can use a catheter introducer.
No, that's quite risky.
Blindly.
At our center, sir, we usually keep the guide wire, sir. And after
Yes.
removal of the cystoscope, we pass the catheter over the guide wire, sir.
Yeah. So
That's
how will you
quite
pass the
reasonable.
catheter over the guide wire?
Sir, we take TUR needle, sir, and we puncture the Foley's just at its tip, sir. We pass the guide wire through the
Yes,
TUR
very
needle
good.
into
Yeah.
the catheter, sir, and then we slide it with after putting lignocancellous.
Yeah, very good. That is most important, and that will be asked in the exam.
Yes.
These are
The other sometimes is a very tough stricture, and you have something called a half moon sheath. The half moon sheath fits
Yeah.
right over the EIU sheath. And if it's a very tough stricture, you can advance the half moon sheath right into the bladder, remove the EIU sheath, and put the catheter through the half moon sheath, and then remove the half moon sheath.
Yes.
That sometimes works for very, very tough strictures.
Yes, sir.
Any other questions, sir?
Yeah. And now, why it is not done in the ventral 6 o'clock position? What is the danger? Young patient.
Sir, because corpus spongiosa is because the urethra is eccentrically placed and the spongiosum is the width of the spongiosum is lesser, sir, at 6 o'clock.
That is one thing. The other thing, no, it's not lesser. The other thing is, how do the erectile nerves, the nerves go through? That's one way. Sometimes you can have extravasation there and infection there, and sometimes theoretically that the nerves might be compromised. Theoretically, that can happen. Now, second, the other point we should remember is so-called, the reconstructive ladder. Is the reconstructive ladder, this is a more philosophical question, is the reconstructive ladder valid in the stricture urethra that you go stepwise for each thing? So you do one and then the second and then the third. But that's a philosophical question. That's not really a question. You can read about it later. So, sir, any other questions, sir?
Yes, that's what I wanted to ask you. Now, if internal urethrotomy fails in this patient, he comes back again to you with a stricture. You do an uroflowmetry in the third month, and uroflow shows there is still once again a stricture. Will once again go for an internal urethrotomy in this patient, or you want to straight away take this patient for an this thing? That is, you want to follow the reconstructive ladder, or you would want to go straight for the urethroplasty?
Sir, I would like to go straight to urethroplasty, sir.
Why?
Sir, because many trials have proven this, that second urethrotomy doesn't help, sir. And also, sir, in the RGU, sir, and also intraoperatively, as we have discussed, sir, the stricture was tight, sir, and more of a involving the spongiosa also, sir. So in this patient, sir, urethroplasty will help him the most, sir.
Correct. Now, in case for this particular patient, if he's going to come back with a stricture within 3 months, there is essentially a failure. There is no point in doing one more internal erythrotomy if he's going to come back within 3 months with a stricture. It's too early for a recurrence or a stricture for an internal erythrotomy. You will go for an erythroplasty. So, what kind of erythroplasty you want to do with this case? With this, we'll go for the questions which are coming from the audience. Yeah.
Sir, in this patient, sir, I would like to do excision and primary anastomosis, sir.
Okay. Do you think it will be easier in this case? The more proximal the stricture is it easier, or more distal the stricture, it is easier for you to do excision?
More distal is easier, sir.
Is it the other way around?
More proximal it is.
Why it's easier more proximally?
For mobilization.
Mobilization of what?
The bulbar.
Mobilization of bulbar, because of you are able to mobilize the bulbospongious muscle from the perineal body. If you release the bulbospongius from the perineal body, it's easy for you to mobilize more proximal segments of the urethra and do an easy anastomosis. The more proximal it is, the more easy for you to do an excision anastomosis in this patient. And Arabind sir was asking you, what is the role of an onlay in this? Can you do an onlay also? Let's go inside. You are seeing the stricture is around 2 centimeters.
Yes, sir. We can do an onlay also.
What kind of onlay you would prefer?
A dorsal onlay substitution urethroplasty, sir.
Why not ventral? It's comfortably sitting in the bulbar urethra. Why not ventral? What are the complications of doing a ventral? One complication, Arabind sir has already told you, there is a chance of extravasation, chance of infection. Joy sir had told you the erectile functions can also be lost. What are the other complications of a ventral?
Diverticulum.
Diverticulum formation. Great. Joy sir and Arabind sir, we have 6 questions actually come from them. So if you are happy with this presentation, we'll give a pass to the candidates, sir.
Yes, sir. Yes, absolutely.
Yeah, sure.
We'll give a pass to the candidates. Any more questions which specifically, candidates, you want any questions to be answered by the examiners, or anything you'd like to ask the examiners before we go into the questions which have come from the audience? Sorry.
Sir, can you know the difference between substitution urethroplasty and augmentation urethroplasty, sir?
Yeah, great. Who wants to take it, sir? Yeah.
So substitution urethroplasty is when you are actually, that's a very interesting question. Actually, if you're going to be a purist, all these dorsal onlay, not substitution, but actually they're augmenting, because augmenting that stricture segment with a buccal mucosa or something. We're going to be a purist. But if you're going to go by the communal this thing, so augmented urethroplasty is when you are actually doing end-to-end anastomosis, but you realize that it's not going to come through because there is enough tissue is not there for it to come together, and then you put that graft. That is the usual definition of augment. But if you are going to be a purist, any dorsal onlay or ventral onlay is actually augmented urethroplasty. You're going to be purist because augmenting tissue there.
To make it a little more comfortable for you in the exams, I'll put it this way for you. Arabind, also you can agree if I'm correct the way I'm putting it. See, what is an augmentation cystoplasty? You excise a segment of the bladder and replace it with something else. So if you happen to excise the urethra, like Dr. Arabind saying, if you happen to excise a segment of the urethral plate and you are going to augment it with some other tubular graft in between the 2 excised segments, it becomes augmentation. When you don't excise a segment, you just open a segment and just substitute it with what you're doing, as buccal erythroplasty, our Kulkarni's technique as well as Barbagli's technique. These are like the entire urethra is preserved. One segment is opened, like a football, one person is coming out, other person is going in as a substitute. Your buccal goes in as substitute, it's substitution erythroplasty. So what you are routinely doing is substitution erythroplasty. When you happen to excise the urethral plate, it is an augmentation erythroplasty. That is where your 6 French becomes important for you. 6 French doesn't go in, you may have to do an augmentation erythroplasty in that case.
Okay, sir. Thank you, sir.
Any more questions you want to ask? Now there is one question. Yeah, please, Sanket.
Sir, I want to know, sir, augmentation and augmented anastomotics, sir.
There's both similar. There's not much difference. You can do augmented roof strip, you can do augmented floor strip, you can do whatever you like. Basically, one part of the urethra you're going to anastomose, The other part you're going to augment with the graft. They're similar. They can be used interchangeably.
Yes.
And Aravind, your takes on double phase erythroplasties nowadays, many people are doing.
That is definitely an option here because here is a short segment stricture here. There will be a degree of spongiofibrosis. Many people will not be happy by putting only. If many people, there's a school of thought which believes that you should not transact the urethra if you can avoid it, avoid transecting the urethra. In that case, you can put a dorsal only, and then from inside, rather than doing a typically ventral incision, you can incise the urethra from inside and put a bit of graft there, so as to make sure that the area of where we have put the graft become wide. Because in the short segment, it might work very well. That's a definite option. So as we say, sir, when you do a reconstruction, you bring all your skills on the table, and at that point of time, you can decide which will work best for the patient.
Correct. And there is one question which has come from Dr. Hafsa from SRM Medical College. If we go with a cystoscope intraoperative in an emergency situation, and if you find a long segment stricture, what will you do? You're thinking it's a short segment stricture. You thought you will be able to put in a guide wire, you'll be able to go through and put a catheter. But you find a long segment stricture, what do you do? Put an SPC and come out?
So it depends on what have we gone in. We have gone into
like this particular case, a traumatic urethral catheterization, we have been called in, we are going in.
So it's a long segment. It depends on if it's completely obliterative, there is no choice. You put a SPC and come out. If it is not an obliterative stricture, if it is possible to do a little bit of EIU or sort of dilatation, you can still put a catheter, because obviously the patient has gone in for some other procedure. And if it is possible to put a catheter and do a EIU, it's not an obliterative stricture, it's a mild stricture. It may be possible to put a catheter, maybe not an 18 French, but maybe even 12 or a 14.
Good. So your take home on this particular thing, Dr. Hafsa, is Dr. Aravind is saying, whenever it's possible to put a catheter, put a catheter. You may not be able to give a 16 or 18 catheter also, doesn't matter. Put a 10 or 12 size catheter, keep the lumen open so that you can do a definitive procedure sometime later on this patient. Correct, Aravind?
Yes, perfect.
Yeah, good. One of them has asked a question, Dr. Kiran Kumar has asked a question. He is not able to understand what is an urethral stricture, what is an urethral stricture disease. So three things we need to explain, Aravind. One is what is an urethral stricture, what is urethral stricture disease, and what is pan-urethral stricture for these students.
So this is it's a very interesting question, and interesting again is a very interesting thing to think about. Urethral stricture, anything, a short segment, anything that is a short segment, maybe traumatic, that anything that causes narrowing of the urethral lumen is a urethral stricture. Now, this narrowing of the urethral lumen may be an isolated event, maybe traumatic, or it may be something isolated because of something very focal, and in which case it can be called urethral stricture. But sometimes you have these diseases of the urethra, like lichen sclerosis atrophicus, so-called BXO, where the entire urethra is diseased, and it's not a short segment anymore. And there could be multiple strictures, or there could be a propensity for obliterative strictures in the future, in which case many authorities would describe the urethral stricture disease. And for that, it is not just merely a surgical disease, but also a medical disease. And sometimes we may need to put something like tacrolimus or something inside the urethra to making sure that it doesn't stricture off again immediately after whatever procedure we do. So this is, again, as you say, it's sort of a philosophical discussion. And pan-urethral stricture, generally urethral stricture disease leads to pan-urethral stricture. And unless you have something like sort of catheter latex allergy or something, particularly after a CABG or something, pan-urethral stricture doesn't usually occur without stricture disease. It can happen, of course, but not common. Yeah. So when you have these BXO on the glands and complete pan-urethral stricture, that is when you will call it urethral stricture disease.
Yeah. So to answer that question for exam purposes, when the stricture starts in the meatus, it is there in the submeatal region also. It extends to the entire anterior urethra and the bulbar urethra. You call it as a pan-urethral stricture. The most likely cause is a lichen sclerosis, BXO change. That's the thing. It happens in only one particular place because of one particular incident, like an injury. Something, as Panda says, some injury, something has happened, one particular place, one particular stricture. Then there is an incident causing a stricture. It becomes a simple stricture. But if it is a disease, it becomes, that is, if it is more than one particular place, then it becomes an urethral disease actually. It is not one particular incident that it caused. So many inflammatory things have added alongside it. Maybe an obstruction like a PXO or something else, an infection along with it. Something has added to it and made it a medical condition. So pan-urethral stricture, single urethral stricture, anything in between will become an urethral stricture disease for you.
Now, there are three terms here, Dr. Chengal. One
Yes,
is single stricture, that's what you have already told.
Yes,
One
sir.
is panurethral stricture, and the third category is the multifocal stricture.
Multifocal strictures.
Multifocal stricture is that one is at the meatus and one along anywhere in the bulbar or in the, and that most commonly happens in case of post-TURP. So,
Sir, Joy, sir, very interesting question which we are coming up now with. When you have multiple strictures, you deal them as stricture disease or you deal them separately as individual strictures?
there is a multifocal stricture that is called multifocal stricture, and the complete line of treatment is different because you can't do, although these are small strictures, we can't do end-to-end anastomosis in all the strictures. Otherwise, we will just jeopardize the blood supply. So in this case, only the flap method is applicable.
Okay. And we have seen many strictures where the submeatal narrowing, and there is also a stricture at the bulbar urethra, and we treat them just by doing an internal erythrotomy at the bulbar urethra and a dilatation of the submeatal narrowing or meatoplasty. That's also fairly acceptable, no sir? As long as the urethra in between is normal.
That's also acceptable. Yeah.
As long as the urethra in between is normal.
Yes.
And Joy sir, one other question that has come up is how is the sexual history important in these patients with the urethral stricture diseases?
It is very, very important, sexual history, because medico-legally also important, because in case of PFU-DD, it is most important. But in case of anterior urethral stricture also, sometimes it is important because one case of OIU can cause a venous leak and IIF lower down the score. So IIF scoring, and to document it before operation, and we have to counsel the patient that we are going to do this operation and it may little bit change your profile, sexual profile.
And Aravind, we have when we were students and all, we were learned a lot about this gonorrhea, chlamydia. Where are these gone nowadays? These
it's very rare now. It's very interesting to know that hardly it is being seen nowadays. I think that is this propensity of doctors to use antibiotics, and most of these STDs are very susceptible to antibiotics. You do find them, but not very commonly. So I think, and also if you look at, I do not know, I have thought of this many times, that if you look at as a class, stricture disease is not very common in the West. It is more common in India, and even in India, if you look at it, it is more common among the low socioeconomic class for some reason, rather than. So I do not. I mean, even if circumcision, whether it's a protective effect, probably is by improving hygiene. That's something that we have to think about.
And one other thing, Aravind, which we have observed, I mean, my postgraduates have routinely observed, is when they do an URS, they do off comfortably and come out. They put a catheter and then remove the catheter after 2 days or 3 days, something like that. When they want to remove the stent, they go inside stricture, sir. I'm not able to go inside. Is it because of the habit that when we were students, we used to do a cystoscope, even for a URS, see the orifices comfortably scope, then come out, then put the URS in so that you know that the lumen is normal even before doing? Or is it because of some trauma we are producing when you're introducing an ureteroscope straight away?
Are these, this is something we have noticed also, are these because of the patients who have these things, do they also have a short suspensory ligament? That is, I think, is a very crucial point. The suspensory ligament is very short. You're very likely to, you have to, when you're negotiating, there's likely to be injury to the urethra in the 12 o'clock to that area. So if the suspensory ligament is not short and it goes through, then I think should not be a problem. And I also think that we should probably use narrower scopes, as you're saying. And if a 6 French can do the job or a 4 French can do the job, there is no need to put the 9.8 scope.
Perfect. Now this is Bhagavati and Ankit. I don't know how many of you observe when we're doing the URS. Many times you're not able to negotiate beyond the mid-urethral level. You think the problem is at the vesicular junction. It's not the vesicular junction. It is a short suspensory ligament in the penis itself which prevents you from going inside. Now, this is something which you should be very careful. Don't always try to push the scope up to the stone. Sometimes you may have to stop and put a stent and come out also. And your movements can also produce an aggravation of injury that could have also resulted in stricture, or even keeping a catheter post-operative for a few days can also be a reason for a stricture in these cases. I thought there are only 6 questions, but Arvind, you have to, and Joyce, there are 17 questions that have come up. You can take it, no?
Sure,
Take
sir.
it as fast as possible. I'll take it as fast as
Yeah.
possible. Most of the questions would have answered. In this particular case, should we prefer to keep an SPC? I think you are given an answer for that. So we need not keep an SPC in this particular case. Can you explain us how the non-transecting erythroplasty is done? And also mention us when it should be done as an option.
Very interesting question. So non-transacting, I believe it should be done when there is not much spongiofibrosis, particularly for some congenital narrowing or only mucosal narrowing. Because the non-transacting, basically what we are doing is cutting out that stricture segment circumferentially and bringing the mucosa together from the inside. So without actually transacting the spongiosum, so that keeps the blood supply intact. While that is of course possible technically, but with spongiosum, with the extensive spongiofibrosis, that may not be a great option.
Yeah, so very rare to find mucosal strictures alone, as Arvind is saying. I have seen a few mucosal strictures alone in cases where we have used BCG. When you try to take that infant feeding tube out, the BCG-induced strictures many a times happen to be mucosal strictures. Apart from that, very rare to find mucosal strictures alone where you find clear indications for doing an non-transaction erythroplasty. Sir, can you explain augmented roof strip and floor strip? This question from Dr. Kumar.
Sir, it is the augmented roof strip and floor strip is basically, it is as we have already described this, that you do an anastomy, you sort of transact the urethra. After transacting the urethra, if as Dr. Chengalvarayan explained so eloquently, it may not be possible to bring the ends together. So in which case you bring one end together, whether it is on the dorsal surface or on the ventral surface, and the other part we have to augment with the graft or with the flap, whichever way, whatever tissue we want to. So that way, if we put it on the dorsal surface on the top, we call it a roof strip. On the ventral surface, we call it a floor strip. But actually, as at the floor strip, there can be a lot of complications. Most people will prefer to do it in the roof because there is less chance of a diverticulum and less chance of a leak there because you have tissue behind it.
Good. Thank you,
Dr.
Yeah.
Chengal.
Yes, sir.
So in exam scenario, most of us, we should not tell the examiner, for the students only I am telling, that I will go for the end-to-end anastomosis or this one or that one. Our answer should be that, yes, after opening, I will assess the size of the length of the stricture and the degree of spongiofibrosis. And after excising the part, then only I will decide which operation I will do. If I will get a good amount of urethral plate, at least minimum 5 millimeter, then augmentation erythroplasty, what they have asked already, it is good. If we cannot make the two ends together, we think that it is a small length stricture, we divided it as Dr. Arabind already taken, and after making the roof okay, we see that the both ends cannot meet, then augmented roof strip or full strip can be done. But in case now the question is that my initial question was that we should divide the stricture according to whether it is a proximal bulbar or distal bulbar. Now all these things are theoretical in distal bulbar. Whether we do it dorsal only, ventral only, or lateral only, these are all theoretical. Ultimately the outcome is same. But the ASOPA technique we usually don't do. But in the proximal bulbar urethra, always it is better to perform a ventral only. Remember this for the students and things, because in the ventral only there is enough bulbomembranous spongiosa. So it is easier to do ventral only in proximal bulbar urethra. In distal bulbar, whatever method we use according to the situation after opening, then only we'll take the decision. I think, Dr. Arabind, and you can elaborate.
Yes, absolutely, sir. I agree with you. When you do a ventral only, spongioplasty is very important.
Yeah.
So the spongioplasty, there has to be spongiosum for doing the spongioplasty. So it is easier when there is enough spongiosum. When there is no spongiosum, then ventral onlay is not a good idea. You can do a pseudospongioplasty, but that's not the same as doing a spongioplasty.
And Arvind, one Dr. Karan as well as asked, sir, inlay, onlay, I'm getting completely confused. What is this inlay? What is this onlay?
Again, this is, if you look, if I'm going to cut inside the urethra and I'm going to put a graft, I would call it a inlay technique. And if I'm going to mobilize the urethra and then cut the urethra and then I'm going to put a graft dorsally, it's going to be a onlay technique. But this is again semantics, where some people will think, but basically onlay is when you are putting it on the spongiofibrosis, spongiosum and above the spongiosum, on the say crural body, on the crura and all that, and then you are actually tacking it. Then it will be onlay technique. When you're cutting inside the urethra, internally, and putting a graft, that will be inlay technique.
Okay, fine, good. I think Karan, I think that answers your question. There are one question has come again, one from Dr. Gaurav, one from another doctor also. Why you're calling anterior urethra a stricture and why you're not calling posterior urethra as a stricture?
Yeah, that's a very good question. There is something called a posterior urethral stricture. What you have in a pelvic in a distraction defect in a pelvic fracture and a distraction defect is basically a distraction defect where the urethra is pulled apart. It's not a stricture. When you operate on this distraction defect and the surgery fails and you get a narrowing, then it is called a posterior urethral stricture.
So for them, what the textbook used to say for them is whenever there is some corpus spongiosum covering, and that is the reason for the stricture, you use the term stricture. When a corpus spongiosum is not there, they generally don't use the term stricture. They use the term posterior distraction defect or a stenosis or something like that. But you do get strictures in post-radical prostatectomies. These strictures are more of the posterior urethra only. You call them as strictures only. Although your textbook definition says that spongiosa should be there, but practically post-radical system there is no spongiosa. Still, they are called as strictures only. But anyway, for your exams, you will say whenever corpus spongiosum is there around, we'll call them as a stricture. Corpus spongiosum is not there, we'll call them as either stenosis or we call them as distraction defects. And this question once again has been asked repeatedly. Sir, what is Joy sir? Which is a short segment stricture? 0.5 centimeters, 1, 1.5, 2, 2.5. What is the short segment stricture in your definition?
It's a 1 to 2 centimeter. Less than 2 centimeter is a short segment stricture. More than 2 centimeter, it's a long segment stricture.
Correct.
According to the definition. Yeah. But but let me come. But that also depends after exploring what is the exact length, because the urethral defect comes after debriding and after cutting and during the operation, intraoperative decision.
Yeah. Perfect. Now this has been saying again and again, intraoperatively you have to make a call.
Yeah,
You think it's 0.5 centimeters, but if you go and say another 0.5 this side and 0.5 that side will add. And one other point Dr. Arabind was trying to make is the degree of spongiofibrosis. Bhagwati, is there any method intraoperatively for you to know the degree of spongiofibrosis intraoperatively?
Sir, we can inject a dye and...
what dye? How do you inject? What does it mean?
So methylene blue we can inject and...
Where you will inject?
Sir, periurethral we can inject, sir.
Periurethral you will inject, or that means you have not understood the concept. So you will inject the methylene blue over the wall of the corpus spongiosum. If the spongiofibrosis is thick, the methylene blue will not come into the urethra. If it is not thick, it will come into the urethra. If it comes into the urethra and stains pink, mixed with the urine, that means it's a good sign. There is no spongiofibrosis, not much of spongiofibrosis. This is once again a question that may be asked by some of the exam. I think Dr. Venugopal sir asked this question some time ago when we were discussing about posterior urethral strictures. Anyway, fine. And then the other thing is, sir, this question again has been asked in an RGU. How shall I read the RGU from an exam point of view? I think, Surendra, can you go back to the RGU? How to read an RGU from an exam point of view? There are just 2 more questions, sir. After this, we'll take just 2 more questions and we'll finish up. Yeah. Meanwhile, Joy sir, is an posterior urethral visualization always a must in your cases of anterior urethral strictures. You would have done more than 1,000 cases of urethral strictures. Once you cut in, you are easily entering the urethra. Posterior urethra has always been normal when we go inside. But still, on an exam basis, we insist on visualizing the posterior urethra also whenever possible. Is the posterior urethral visualization absolutely necessary in cases of anterior urethral strictures? That is also one of the questions.
It is absolutely necessary. While we put a Brooke-Walter retractor, ventral or dorsal urethrotomy, we need to pass a cystoscope through the urethrotomy defect and look till the bladder neck and bladder. If everything is okay, then only we go continue with the urethroplasty.
And whenever possible, if you do an MCU or VCU in this patient, that also defines the length of the stricture.
That also defines length of the
When you forcefully inject the dye from below, it appears as if the urethra is dilated, posternodal dilatation above the stricture. But when you see from the dye from above, you know that the stricture is actually a little longer in length. So it's one of the reasons why you ought to do an MCU. But if you want to do just a DYIU and come out of this patient, is a posterior urethral visualization a must for you still, sir?
Sometimes
Theoretically, yes. Theoretically, yes.
Yes. Sometimes unexpected findings, the stays in the posterior urethra. Sometimes there is diverticulum, sometimes false passage, and all these things we need to visualize.
So till these candidates pass the examination, we have to say that the posterior urethra has to be visualized. They don't have a choice.
I think it's good.
Whenever possible.
Contrast should pass to the bladder. That is what they should say.
Arvind, now if on your RGU the contrast goes nicely into the bladder, will you still do an VCU?
Will I still? No, sir, not required.
Yeah, not required. That's right.
Not required. Absolutely not required. If the RGU is showing the contrast going into the bladder, it's not required. But in the exam, they have to say that the RGU is a test for the anterior urethra. I cannot comment on the posterior urethra because even if the contrast goes into the bladder, it doesn't distend the posterior urethra. That's what and the bladder neck. But if it goes through into the bladder, it is not required to do an MCU. It's not required at all.
Yeah. So you can defend yourself. If it goes into the bladder, it's not required. But if the examiner insists that it's not undistended posterior urethra, you have to see. Just go with the examiner.
Yes. Then you say that absolutely I will do.
Yeah. There you have to say the other way around. But practically, as Arabind says, if this goes into the bladder, generally we are going to do only a DVIU. We go ahead with it and complete the DVI. If you're going for the urethroplasty, then yes, you have to visualize the posterior urethra. That is a must for you. So you go back to this X-ray. Arvind sir and Joy sir, both of you. And somebody wants to know how to read an RGU. The one other question was why it is going parallel to the femur. Of course, it's going parallel to the femur, but it's not overlap on the femur. The urethra should go parallel to the femur. It should not overlap on the femur. That's an important point here. Yeah, please.
Sir,
Ankit, can you describe? Then Panda sir can help you. How do you read an RGU? I think with this, it's almost 9 o'clock. We'll take this as the last question.
Yeah, we need to see the scout film first and then make the patient in the left or lateral right oblique position. And it's already we know about how to perform a retrograde urethroplasty. And we should put the penis on a little bit stretch and then perform and as you have already told that one of the acetabular foramen should not come and we should not see. And then we have to see the length of the stricture here and the degree of dilatation of both proximal as well as the distal urethra. In this case, the distal urethra is good. It is of good caliber, but sometimes it is of less caliber, and then we have to think about that there might be some panurethral stricture. So that's all about it. Scout film and both left and this oblique, left lateral oblique. And in MCU also we have to mention about is there any viewer or not, vesicoureteric reflux.
Arvind, any more points you want to add?
So basically, there are
urethral diverticulum. Yes.
So it's wonderfully put by Joyce. I just wanted to add that initially they should, as I said initially also, that we should ask to see all the films. There are multiple films of RGU before we comment. And we have to first check for the technical adequacy of the film. That is the exposure okay? Are we able to? Has the patient been put in a proper oblique position? And secondly, is the contrast concentration okay? If it is too dilute, you're not going to see it properly. And as we said, has the contrast gone all the way, the RGU all the way into the bladder. And then you look at the landmarks, as Dr. Chengalvarayan just said previously, that only one of the operator foramen should be visible, and the urethra should be parallel to the femur. This is very important. Then you will be able to see the entire urethra. And as sir said, as Joy sir said, it should be stretched as much as possible. Sometimes you can see that the urethra is not well stretched. It should be stretched as much as possible, and there should be distension of the urethra. So the contrast amount injected should be in a way that distance the urethra. There's something also called a sort of a dynamic RGU, where as the contrast is, you feel the contrast going up to the bladder, you ask for the radiographer to shoot. Or if it is possible and you have a fluoroscopy can be used, so the entire urethra going or entire contrast going into the bladder can be seen. So once we have seen all that, we need to again see the landmarks. Where is the bulbar urethra? Where is the membranous urethra? This has all been described already by Dr. Chengalvarayan. And then if there is any narrowing or any irregularity or non-distensibility of the mucosa, these should be mentioned. A stricture, it should be mentioned where the stricture is, what is the length of the stricture, and whether there is distal and proximal ballooning of the urethra. If there is any sort of irregularity, that should be mentioned. As Joy sir was telling, if there's any diverticula anterior, it should be mentioned also. And if the fossa navicularis is visualized, that should be mentioned. But remember, the RGU does not a normal RGU does not mean that the meatus is normal. The meatus and the submeatus area is best checked by calibration and not by an RGU. That is something, again, that could be a question that can come. So if you have a narrowing in the meatus, you can miss it even if the RGU is normal. And if the flow is poor on a flowmetry, you should ask for a calibration of the meatus and the submeatus area with a Foley's to make sure that that part is normal. I think that what I'll say.
And then how do you assess the length of the stricture?
That's very interesting, sir. That is very interesting. If we one way is if we're doing an MCU, one way is to put a sort of a assess the vertebral body or something like that, and then you know that is that length and then use that as a scale to see the length of the stricture. This stricture obviously is short segment, but something is longer than that, you might need to put a check length, height of the vertebral body and sort of extrapolate it. But even because they're not at the same level, you can still have a little difficulty, but you will roughly get an idea about the length.
Bhagavati was using one terminology that if you measure the thickness of the inferior pubic rami, it corresponds somewhere around to 2.5 centimeters.
That's also okay, sir. So we have to have a reference length and use that reference length for the.
Oh, correct. When we were students, actually there is a classical 17-14-inch film where we can say I can measure the length and minus 13%.
Yes, sir.
30 to 18% magnification. I can minus that and easily I'll carry a scale. Examiner will ask you, where is your scale? Now these films are all miniature films. So you can't go with the scales.
You cannot do
so you have to probably go with the landmarks like a vertebral body or an inferior pubic rami to say where exactly the length is. Joy sir, one last question for you. Do you routinely ask the patient you have a contrast allergy when you do an AUG? Will you routinely give antibiotics?
Yeah, we are using antibiotics before performing any type of contrast study, just like this.
Okay. And what about any contrast allergies? Do you ask for contrast?
We ask for contrast allergy. The reason in this, sometimes there is tight stricture and there is venous intravasation. So that is very, very important. So we should ask the patient about contrast allergy.
Yeah, extremely important, sir, because in our practice, many of our students or radiologists are not used to asking contrast allergies, thinking it's only going through the urethra. But in a tight stricture, there is a chance that it can intravasate. And we have even seen IVC also during doing an AIG intravasations. So that kind of things can happen. So pushing in a contrast doesn't mean through the urethra that patient may not have allergies. Small mucosal injuries will their contrast allergies, you have to ask. So contrast allergies, you have to ask, and antibiotics, you have to give as a must when you do an AIG. So thank you very much, Joy sir, for joining us, and Arabind Panda. Great. It was great. I think Ankit and Bhagavati also did a very good job interacting. And I think I'm happy for both Arabind as well as Joy. Not only they did a very good job of doing an examinership, they gave me the opportunity also to talk. Because many a times the examiners may not give an opportunity for the moderator to talk. You gave me an opportunity for me to interact also with you. Surinder, as always, wonderful. You had been presenting for the 6th consecutive time. And Mankind, Arabind and Joy sir has been very supportive. Mankind is comparatively a new firm as far as urology is concerned, but these people have taken the job of helping us with these LUME program. So thank you very much, Arabind sir, as well as Joy sir, for joining us. It has been wonderful having you, and we'll be having more programs in the future. And you'll be one of the most sort of examiners. So sometime or other in a few months, you may be back with us also.
So thank you for having us.
Thank you.
It was absolutely wonderful, a great honor, and it's always a pleasure to be associated with any program with Madras. It was absolutely great. So thank you so much.
Thank you, Arabind. Joy sir, thank you very much. Thank you very much.
Thank you, sir. Thanks a lot.
Thank you, Ankit. Thank you.
All participants learned a lot. Yeah. Thank you.
Yeah. Thank you.
Good